Good afternoon. I think we should. Is it on? I don't think the mic's not working. Oh, okay. Oh, there it is. Good afternoon, everyone. It gives me great pleasure to introduce Dr. Carlos Zarate. Dr. Zarate went to medical school at the Catholic University of Cordoba, Argentina, and then completed his residency at the Massachusetts Medical Health Center and the Brockton VAMC. From there, he moved to faculty positions at Harvard and at the University of Massachusetts Medical School before moving to the NIH in 2001. He's currently the Chief of Experimental Therapeutics and Pathophysiology branch at the NIMH. Dr. Zarate is, without exaggeration, one of the world leaders in performing clinical trials.
You get closer to the mic, otherwise you get the feedback.
Closer?
Yeah.
Okay. So he's a world leader in performing clinical trials with rapid-acting experimental agents for the treatment of major depressive disorder and bipolar disorder. He's published over 350 papers, won numerous awards, is on the editorial board of multiple journals, including Lancet Psychiatry and Biological Psychiatry. And he's been awarded a number of patents, notably one for ketamine for the treatment of depression. And the timing of his visit is actually quite auspicious because you probably know that ketamine received FDA approval last month. And Carlos was the lead author on the first clinical trial to show efficacy for ketamine in the treatment of depression. The title of his talk today is Deconstructing the Neurobiology of Mood Disorders Using Rapid-Acting Antidepressant and Antisuicidal Interventions as a Bridge to Novel Therapeutics.
Can everybody hear me? Yes. Okay. So thank you so much for the introduction and for everybody for giving me a very nice warm reception. It's been a great day and a half so far. It's going to probably get feedback. So what I'll try to do is summarize research that's for clinicians, for therapists, for psychiatrists, trainees, and also for neuroscientists. So I will provide a general overview. Yeah. So what I'll do is summarize the work we pretty much have been doing for the last 15 years. And this is my funding. I work for the U.S. government, and as already mentioned, we have a patent which was by the U.S. government and two other institutions that led to the approval of ketamine that's currently on the market. So this is a summary of today's, the outline of today's talk. I'll provide a very brief overview of concepts of depression and suicide, discuss the neurobiology of depression and somewhat suicide, and then I'll deconstruct the neurobiology of mood disorders using ketamine as a tool. So most of you do know that mood disorders are common chronic conditions, and it is the leading cause of disability worldwide. And people with SMI, serious mental illness, including treatment-resistant depression, have a shorter lifespan. In fact, people live on average 6 to 8 years less. They don't have depression. And it's a very deadly illness. About 1 million people die of suicide worldwide besides the shortened lifespan. And the pain and suffering that goes with depression is tremendous for those who have chronic treatment-resistant depression. Depression, it has been originally perceived as disturbance as a mood and behavior. We know it's much more than that. Circadian rhythms, activity levels are key components into more recent concepts of depression. And depression is viewed now as disorders of synapses and circuits that are implicated in mood disorders. We focus on treatment-resistant depression. If you have TRD defined based on 2 antidepressant failures in a current major depressive episode, you have more psychiatric medical comorbidity compared to non-treatment resistant depression more hospitalization, 9 times. The costs are staggering compared to non-treatment resistant depression, and there are greater rates of suicide. So it's a very important group to study. This is what I mentioned. This is disability adjusted life years. And you may know or not that neuropsychiatric disorders, specifically mental behavior disorders, are the leading causes of the U.S. burden of diseases, among 291 diseases and injuries. So not only is it associated with significant morbidity, but with significant mortality, but also significant morbidity. Most of you are familiar with the current classification, DSM. We describe our patients largely based on symptoms. You might have depression, anxiety, suicidal thinking. The concept of anger, hostility has been dropped from classificatory systems over the years, but anger, hostility is really a part of depression. It could be inward, which leads to suicidal thinking or attempts, or outwards violence. In addition, patients with, in DSM-5 now, you may have symptoms of hypomania in association, in addition to major depressive episode that does not meet the criteria for a full hypomanic or manic episode. And then you may have cognitive disturbances. Now we know that depression is much more than depressive symptoms, we view it now as a systemic and brain illness. And if people want a copy or PDF file, I can send this to you. On the systemic, we have patients with depression have higher rates of migraine, thyroid disease, hypothalamic pituitary adrenal axis disturbances, including the stress hormone cortisol, their innate immune system disturbances, and you can see a number of different of these things. Cardiovascular, there's increased risk of heart attack, if myocardial infarction and death if you have depression compared if you don't. GI system in bone and body fat disturbances. And towards the right, here are the brain. These are some of the findings, some of our findings and others. The sleep impairment, circadian decreases in REM latency, and synaptic plasticity and alterations. My point is, as clinicians, we focus on sleep and maybe activity levels and irritability, but we should be focusing on many of these other systems. Now, not saying that all our patients have all these different components, but they have some aspects of it. In the future, we will not only give our SSRIs, but we'll give treatments that address these other components. So, if you are working with, you should be working with your internist and other medical providers to make sure some of these things are addressed. Now, some of these things are more research and not ready for prime time, but just to work closely as a team in taking care of your patient. So why do we need new antidepressants? We have over several dozen antidepressants, and we had a very lively talk last night over dinner on the drug development. But to summarize that, most of our discoveries were serendipity, including ketamine to a certain degree. And we have our traditional SSRIs, monoaminergic-based antidepressants, and then we have, that was viewed as too many side effects, and then we cut down, to make them a bit more tolerable, savor an overdose. But largely, I would say after 50 years, we pretty much have Me Too drugs. Pretty much, there aren't any antidepressants that have a significant advantage over other treatments. And the STAR-D study looked at remission rates in 3,000 outpatients, and what you could see is there were 4 levels of care. Trial 1, which were either medications, and you had medications or some type of therapy, either alone or in combination. And you can find that over the course of several trials, remission rates go down significantly. Here, you can see it takes 2 antidepressant trials or 6 months for half of the people to achieve remission. Just think of that. 6 months for 50% to achieve remission. That's, in my mind, pathetic. We've got to do better. And after 1 year of 4 levels of care, still 1/3 of patients are not achieving remission. So the problem with our current medications is we see very low remission rates. There's a delay of onset of weeks to months. we see that during that problem, you're asking your patients hang in there until the medication kicks in. So they have personal, social problems. They may lose their jobs. For that matter, they may even attempt suicide. Greatest risk of suicide is the first 7 days to 30 days of starting an antidepressant. So that's why we have to come up with better treatments. Now, compared to cancer, where you might have a target, infectious disease, you might have a target. What are our targets to develop new treatments? And you can see the sheer complexity of the brain trying to have, look at the monoaminergic system, drugs we've been developing for many years. Then there's the neurochemical, and then there's the circuit level data. So you can see that it's easier said than done. So what we propose is using ketamine as a tool to help dissect the biology, the complexity, to come up with more simpler constructs. Now, where do we have a limitation on our treatments? It's summarized here. This is DSM diagnosis. You know, I'm a clinician, many here in the audience. It's a common language that describes psychopathology. We can all agree if somebody has depression here that they meet criteria, 5 out of 9 symptoms. However, in reality, you can see there's a tremendous overlap. So let's say I'm interested in the genes of depression. Let's study it so we can find better treatments. Okay, but look at the intersection with all these other conditions. In fact, 40% of our patients have some of these other comorbid psychiatric conditions. This is not even including medical conditions. So are we studying the genes of depression, or the psychosis, or obsessive compulsive disorder, or trauma, right? When DSM was created, I was involved in DSM-5 committee, and the truth is we look at the literature, we sit in a room, and we talk about agreeing that these criteria meet, major depressive episode. But that does not map onto pathophysiology. So what has been proposed is the RDoC, where what you would do is look at more simpler constructs. When I say simpler, they're quite complex themselves. For example, you could look at activity levels, which doesn't matter. You might have increased or decreased activity levels of psychosis, mania, depression. You can look at suicide. You can have suicide even if you have no psychiatric diagnosis, right? So people who have schizophrenia. And what you do then is you look at several levels of biology all the way, or behavior, going from behavior through physiology, circuit cells, and genes. And if you fill in the gaps of knowledge, that might lead to a better understanding on what these conditions are and hopefully better treatments. At least that's the strategy. One example here is, for example, anhedonia. We were able to show in an earlier study you can rapidly decrease anhedonia with ketamine within 40 minutes, lasting 2 weeks, and it's linked to dorsal cingulate cortex. And so then that gives you a target and a relevance. And that's the strategy that's being employed. Now, there has also been, as you know, the personalized treatment. And this is an example where you have individuals here, they're highlighted in different colors. And what you can see, they're composed of all these different diagnoses: bipolar depression, mild depression, major depressive disorder, and probably depressive symptoms. So if I were to give Prozac here, let's take an example, anti-inflammatory drug, the anti-inflammatory drug aspirin would not work here, right? Why? Well, it's possible that there are subgroups that have predominantly depression caused by inflammation. And so if you could identify that group, your aspirin would work, right? The trick is how to find it. And so people have been looking at these data sets from a genetic brain activity physiology, and then you come up with clusters. And let's say cluster 2 is inflammatory type of depression, and aspirin should work. At least that's what's believed, the theory. And so people have used resting state connectivity. And here you can see these are maps and looking at the networks involved in depression. That you have the central executive network, dorsal network, so on and so forth. And what this study did, the Drysdale study, was said, okay, let's leave symptoms out of the picture. We're going to do brain imaging, resting state, 1,000 people who had treatment-resistant depression, and they came up with 4 biotypes, biotype 1, 2, 3, and 4. And they found here that in one of the types, you couldn't find a pattern of anxiety or anhedonia or depressive symptoms. And so then the question is, so what, right? At least clinicians will get a sense if you're having insomnia, you can target something for insomnia. So what they did is they tested the relevance by looking at 120 or 140 subjects who received TMS. And they found that one of the biotypes responded better to TMS. So this is an example, right? People are moving into machine learning and other aspects. The problem with this is this study, which was published in Nature Medicine, I believe, was not replicated recently. And so again, this is very early work, but it gives us an idea of what people are trying to do. Now, what do we need new treatments? Well, I already mentioned the adverse effects of depression. We have low remission rates. Lag of onset is a key one. And in fact, this is a major depressive episode. If you give an antidepressant, currently the available Zoloft, Prozac, Wellbutrin, it takes 10 to 14 weeks for about, to get a good response. And in fact, what our work is focused is on, okay, that's unacceptable for the many reasons I mentioned. Let's look at treatments that give a response within a few hours. That's realistic. So, but to do so, we have to identify new cellular and molecular targets. Now, moving away from the neurotransmitter systems, we're looking at that mood disorders, severe and recurrent, are associated with impairments of plasticity. These represent brain circuits and synapses. And you can see here people who have a healthy synapses and circuits, it looks like a tree in spring, whereas people with depression, it looks like a tree in winter, deprived of the leaves and the branches. And no matter how much water you give it, it's not going to absorb and the tree won't grow. So what we need in addition to regulating the neurotransmitter are what we call plasticity enhancers. What you do is you move from here to the right to the left. And there are a number of factors that are implicated. Growth factors, there's these natural growth factors in the brain. There's the chemical glutamate in the brain, which is the neurotransmitter that's being focused. And there are problems with inflammation, oxidative stress. There are many factors. So in fact, this is a cartoon of the presynaptic neuron, postsynaptic neuron, the synaptic space, and where a drug like ketamine, which is the prototypical drug for the next generation of antidepressants, binds to this receptor called NMDA receptor. And glutamate is tightly regulated. What happens in excess levels, it leads to shriveling of the synapses and circuits. This happens in people with believed to be neurodegenerative conditions, Huntington's, Parkinson's. And so people looked at these drugs to protect these receptors because these receptors are involved in learning, memory, and plasticity. And so what has been found is, if you recall here, the shriveling, atrophy of synapses, circuits, reduction in brain volume is that ketamine within, at least in these preclinical models, within hours, increases the spines and synapses. Okay, within hours. Now, does that translate from mice to humans? Who knows? But that is the work that's being done. So there's something unique about ketamine here. Now, this slide is actually busier every week that goes by. These are some of the drug targets that regulate the excitatory amino acid glutamate. And we have tested ourselves many of these different drugs, and I won't go into detail, but let's start with ketamine. The assumption of ketamine is that it blocks this NMDA receptor, and that's why it's a very unique antidepressant. However, because it blocks this receptor, it's associated with dissociative side effects and the risk of abuse. Okay, and that's very important. Can we develop better drugs, safer drugs? So this is a brief story of ketamine's history. PCP was developed as an anesthetic agent. But people who took, because it would not, compared to other anesthetic drugs, significantly affect cardiovascular and respiratory function. So that's an advantage. But it produced dissociative side effects that lasted for a long period of time and emergent reaction. And so what happened here is that ketamine was created by Park Davis. It's a long history if you want to do that for the question and answer, but in essence, it was deemed safer, still had the dissociative side effects and the abuse potential. But in 1970, it was approved by the FDA for as an anesthetic and analgesic agent, and it was used very commonly in the Vietnam War, where it reduced mortality from soldiers because up to that point, morphine was used during the Korean War. And so here, mortality was decreased by the introduction of ketamine. Now, it's a long story, but What is ketamine? It's a dissociative anesthetic, and I'll talk about that. Your mind is disconnected from your body senses while you're taking ketamine. It's also used by veterinarians as a tranquilizer, and it's also abused recreationally. And its bioavailability is 100% intravenous. People don't give the pill form because it doesn't absorb very well. And keep in mind, this is something key that I'll come back to later. Its half-life is 2 hours. Okay. Now, this is the NMDA receptor I mentioned. It's a channel where ions flow, very important for learning and memory. Here is the PCP site. With ketamine, here are the ions, but ketamine binds to this PCP site, and you can see that it does not permit the flow of ions, so thus, while you receive ketamine, your learning and memory is affected, right? And you can have different syndromes. Psychological is only during infusion, which lasts 40 minutes, decreased awareness of environment, sedation, dreamlike states. You might have dissociative side effects where you have out-of-body experiences, changes in perception. And you can have increases in blood pressure and heart rate. And there's the risk of abuse intolerance. So ketamine was used back in the 60s and 70s as a psychedelic drug in addition to psychotherapy. In this portrait by Marissa Bassett did describe what they called is the ketamine tiger. This is the K-hole. The tiger, you have to have control, you may lose control, and then you have the different isomers of ketamine, or stereoisomers. You have the R and the S, and then it has effects on the brain. Now you might say, okay, why would I want to give this to somebody who's suffering tremendously? Okay, your vantage point differs from that of if you don't have depression to somebody who's in that depressive state. In fact, for ethical reasons, we talked about this last night, it took a long time to even get to study this drug. The point, we studied people with severe treatment-resistant depression. They had failed on average 6 antidepressants, 50% failed, 60% failed ECT, the most effective treatment, and 50% had previous suicide attempts. So IRB committees were saying, okay, give them the alternative to ketamine, and he says, well, there is no alternative for treatment-resistant depression. So people had failed many options. And so the question is, if we give one infusion of ketamine for 40 minutes, would that bring about rapid antidepressant effects? And here you can see the answer is yes. These are depression scores, Hamilton, and it goes very rapidly from moderate severe depression. Within 2 hours, you have an antidepressant response. And people would fail 6 antidepressants and failed ECT. Towards the right, you see response rates. Okay, here are the monoaminergic antidepressants. We take a pill every day, Prozac, Zoloft, Wellbutrin, and you get about 60% in 8 weeks. With ketamine with one infusion, in people who are treatment-resistant depression, these were not, you get comparable response rates in a few hours. Okay, so we said, oh, there's something here. Why not continue studying it? And that had led to a series of studies, and I could talk more about that. But just to give you a sense of, these are 12 of our second-generation antidepressants, the Zolofts, the citalopram, the duloxetine, and these are what we call the odds ratio of having a response. The greater the number, the better the response. And you can see here they hover about 1. These are the acceptability in terms of side effects. Citalopram is better tolerated than fluvoxamine. And you can see here where ketamine is an odds ratio of 11 versus 1 within 1 day, as opposed to 8 weeks. Okay. So I got interest, of course, the path went for clinical development. I'll summarize that briefly, but it more as a research tool. So these are the next steps in ketamine research. Okay, so 1, clinical practice. So the FDA approved S-ketamine for TRD, known as Spravato, intranasal use. In fact, this is a very brief summary of the program. I'm not going to get into detail, but they had short-term studies, maintenance studies, and long-term studies. Here is, towards the left is better than placebo, to the right worse than placebo. And you can see here, these are the confidence intervals. You can see here, once it crosses the line, it's probably not better than placebo. So you want to be left to this line. So you can see here, this is the main study that Janssen used for FDA approval. The others are on the fence, but there's a whole other story. When you go into the real world, it's much different than in research settings. This is what we call the proportion, the time it takes to have a relapse, and this was pivotal to the approval. So you can see here that if you take an antidepressant with placebo, you're more likely to relapse quickly compared to take as ketamine after stopping 16 weeks of open label as ketamine. And these are the dose recommendations for now for intranasal use. For weeks 1 and 2, you do 2 times a week. This is the starting dose, and again, I can give you this PDF file. And of course, if you're elderly, you take the lower dose to 28 milligrams as opposed to starting with 56 milligrams. And towards the right, after weeks 4, 5 to 8, you can go to 1 time a week. So it's pretty much similar to what is done for ECT to a certain degree. And people have stayed well for periods of time. In fact, relapse rates were double for the placebo compared to ketamine condition after stopping as ketamine. The second is, ketamine, as I showed you, blocks this NMDA receptors, have several subunits. Subunits would be, this is a building with several rooms in it. Let's say this room is responsible for the efficacy, next door is responsible for side effects. Ketamine hits all the rooms in this building. So what we and others have tried to do is let's focus on drugs that are selective for this room. And that's what we refer to subunit selective drugs. And I have a slide that summarizes our work over 10 years. And towards the top, rapid onset, check. Robust separation from placebo, and then sustained efficacy. Ketamine has all these conditions. However, memantine for Alzheimer's, which is an NMDA antagonist, didn't have anything. We tried a few other drugs that didn't really. There's no other drug that came close to ketamine. Now, it might be because ketamine has very broad effects in different systems within the brain and the body. Okay, so the next is, can we understand the mechanism of action? And this is before I get to the suicide part of the talk of suicide, if I have time, to use ketamine to get an understanding on these different levels of biology as I mentioned. And so taking advantage of the Intramural program in NIMH, all our patients get these procedures after being tapered off their medication on an inpatient research unit during experimental treatment, and again on follow-up. And I'll give an example. They get sleep studies, they get PET imaging, they get neurochemical studies, MRS. We look at neural activity. This looks like the X-Men, if you ever see, Magneto, kind of. Then there's functional imaging and then structural imaging. And it gives us information at the molecular cellular circuit, and we have information on the genetic level. We think that this, within the same individual, will give us more insights to how these drugs work. So this was a very ambitious study that started around when Tim was there, maybe. And Tim was at the Intramural in IMH, great guy. This is a multimodal biomarker study obtained longitudinally before, during, and after experimental intervention that will permit us, the science today is Polaroid picture, depressed brain versus healthy brain. That's it. It's a bit simplistic. What we try to do is the depressed brain, or the suicidal brain, get them out of that within a day or two with ketamine, for example, or some other treatment. Study that depressed and suicidal brain when they're no longer depressed or suicidal. And then when the effect wears off, they go back to the depressed and suicidal state, so you can get a sense of the link of symptoms with biological changes. So it's a crossover study with ketamine or placebo. And subjects were depressed, 2 weeks drug-free in our research unit. And we give healthy control subjects. There are many studies that report on biology only with a single open label. No control condition, and healthy control subjects are very important to study. So this is to give you a sense that our subjects were mildly depressed. 40% had previous suicide attempts, and they had been ill for 40 months on average. Moderate to severe depression, high levels of anhedonia, lack of pleasure. This table summarizes the richness of the data set on 60 subjects. So we obtained 20,000 ratings. We obtained about 500 structural functional scans and about 400 sleep studies. in 6 or 7,000 blood samples. And so it led to a series of papers that I'll just summarize very briefly, looking at function, neurochemicals, and neural activity in the brain. And also, I won't talk about, but peripheral biochemical measures as well. As expected and shown previously, this is depression scores, higher number of worse depression, time in minutes, in hours. We see an onset of antidepressant effects within 1 hour. Remember, these are treatment-resistant depression, and it lasted in this study 11 days. Okay, and what happens? This is a CAS measures dissociative symptoms. You can see it peaks at 40 minutes, and if you're a clinician, you work with patients with intranasal, it will peak at 40 minutes, but it's no longer gone by 80 minutes. But you shouldn't drive the same day. And this is what we found, that ketamine, compared to the other antidepressant, has pan-therapeutic effects. The effects are broad. You see, not only does depression get better, we see improvements in suicidal thinking, anxiety, anhedonia, loss of pleasure. In fact, some of our treatments, such as the SSRIs, actually worsen anhedonia. In some cases, PTSD symptoms improve as well. Why is it important to study healthy controls? Well, many groups out there study healthy controls saying, oh, if the drug does this thing to the brain, that probably is related to the antidepressant effects of the drug. Not necessarily. Depression is different than healthy control subjects. In fact, the same drug, same times, you see that depressive symptoms actually go up in healthy volunteers. And people remain with significant impairment of inattention, lassitude, anxiety lasted 1 day. Keep in mind the 1 day. I'll come back to that a little bit later. But similar to depressed patients, you see increases of dissociative side effects that go away in 80 minutes. Okay, so right now, and I'm going to summarize, this gets into homeostatic mechanism, the sweet spot in the brain. I'm circling what I'll be talking about, so I'll focus on circuit. One example, fMRI, and this is resting state fMRI. This is the study we talked about. Here in green is the MRI. We get it before the infusion, and 2 days later, and then 10 days later, because I want to see the on-off effects of ketamine. I'm not going to get into the boring details, but to show you in the next slide here, these are depressive symptoms, you remember, right? People at baseline start with moderate to severe depression. You see the difference with healthy control subjects is increased activity in insula. This is, I can talk more about the details in terms of methods during the question and answer session. At 2 days is the peak of ketamine's effect. You can see the scores go down. And what happens with the difference in insula activity compared to healthy controls? It's gone, right? All right, so what? Well, you want to see if it has anything to do with mechanism of response. And you can see at day 10, when the effects of ketamine are no longer apparent, you see the return of the insula activity. So this is a much more powerful way of linking biology to symptoms. Now I'm going to get into another is tasks. This is looking also at the circuit level. I'm using fMRI. Here we've got scans. I'm going to only talk about 48 hours after either ketamine or placebo, crossover study. Here I'm going to focus mainly on the DOT probe, which spans both attention and emotional processing domains. And this is in the DOT probe. Here you have faces. The faces could be either angry or happy. And you can see here, this is, you ask people to fixate on a cross, and then one of the faces is replaced by that cross. It could be either the angry or the happy face. And you do all these tests within milliseconds. And you obtain in the image in these nice bold signal changes. Okay, towards the right, towards the upper right, upper level, you see the right precentral gyrus. You see here towards the left is healthy controlled subjects, and to the right, major depressive disorder after getting either placebo or ketamine. Placebo orange, ketamine in yellow. Look what happens to our depressed subjects after ketamine. You see, bold activity is knocked down. Right. Now, in the direction of healthy controlled subjects who receive placebo, you can see here. But what happens, if you recall, what did I say about healthy controlled subjects when they receive ketamine, they have what? Depressive symptoms that last 1 day. This is at 2 days. Look what happens to healthy control subjects when they receive ketamine. They go from, they look like the depressed subjects after receiving saline, when there's no longer any symptoms of depression. So this speaks that the circuits still remain affected. So this is one example. I'm not going to present emotional processing data. So the next is, at the cellular molecular, we're doing neurochemical studies, and people use MRS to measure glutamate in the brain and other neurochemicals. And just to show you one study at 3 hours, or 3 hours or 2 days did not find any changes in neurochemicals after ketamine compared to placebo. But they used this low field strength. We did a similar study using 7T, and what I present here is day 1, 24 hours after the ketamine infusion or placebo infusion. We looked at pre-general anterior cingulate cortex. When you look at 7T, just to keep in mind that we see this nice peak of glutamate. Most of the lower strength magnets have a mixture of glutamine and glutamate. So it's important to do important to do methods to be able to understand this. And what had been proposed is that ketamine blocks this NMDA receptor on GABA interneurons, and it leads to a flood of glutamate, which activates AMPA receptors. Okay, and we didn't see that at least at 1 day. There's nominal increases in depressed subjects, but not in healthy control. No difference. So we didn't see that glutamate surge. So this study helps us test some of the preclinical studies to see if it has any relevance to humans, and we didn't find it here. Now, at the cellular molecular, this is magnetic encephalography, looking at neural activity, how one neuron talks to another within local regions or across the brain. And this is one of the examples. We look at gamma power. Gamma power actually is a surrogate measure of this inhibition excitation that occurs when ketamine binds to the NMDA receptors on the GABA interneurons. And what we find is in both depressed subjects, in healthy control subjects, you can see here orange, these increases in gamma power in different regions implicated in depression, the triple network depression. And what we did find, though, is if you look in this, we'll get into the cartoon following this slide, is that baseline gamma power, where you start on a curve of gamma power, will be associated with the likelihood of response. And this is common, so low gamma power, you have better response. In high baseline gamma power, you don't have a response to ketamine, or actually you could get worse. Okay, this is very early work, but this is the homeostatic cartoon, inverted U shape. There's too much inhibition. This is the sweet spot, and too much excitation. So it depends where you start. So healthy controls reside at the sweet spot or set point. And if we give ketamine to healthy controlled subjects, what happens? They get depressed for 1 day or less, right? And what happens? Healthy controlled subjects have resilient mechanisms to snap them back into place, okay? But what happens with depressed patients? Well, depends. You could get depression on either side, but if you are down here, ketamine might get you to the sweet spot, right? But if you reside close to the sweet spot, you might overshoot, right? And you could end up with depression or actually worse. And actually, that is kind of what we're finding. So this has implications for other treatments as well. And we showed this at the electrophysiological level, metabolism, emotional processing level. So this is an interim summary. I think I'm okay with time. Yeah, I have about 10 minutes, I think. So we've been obtaining data in these multiple domains that will help us understand how ketamine might work. Very briefly, as I mentioned, we're not satisfied with ketamine. It has its limitations. And this represents extensive work by Intramural, Extramural, University of Maryland, MCATs, and other institutions. And very summarize the metabolite story. Okay. On our research unit, This is racemic ketamine formed by the two isomers, stereoisomers R and S. S, ketamine is on the market now, it's Spravato, right? But if you look at this curve response, we said what? You peak it within a few hours, and then after one infusion starts fading away by the end of 1 week, right? But the side effects last 40 minutes, right? And so we were saying, okay, so we started looking at our patients, and we found metabolites lasting 3 to 7 days. Here. Some of them, there's 24 metabolites, are the hydroxy norketamine metabolites, H and K. So if they last 3 to 7 days after the side effects are gone, so might these be important to the mechanism of action of ketamine, right? In fact, we went in and looked at the old papers, and we found disappointingly that the hydroxy norketamine metabolites, or H and K, had no activity. And we were disappointed, but no pharmacologic activity for anesthesia. Nobody looked at depression. So we looked at depression. This was work led by Todd Gould at the University of Maryland. And so I'm not going to bore you with the details, but hydroxy norketamine was found. One of the 24 metabolites. And this is a cartoon summarizing the work. Okay, so if you take ketamine, within minutes in men and in rodents, you have 24 metabolites. Okay, lasted, some of them 3 to 7 days, correct? Some of them are responsible for the side effects and addiction, right? And some of them would be responsible for the efficacy. So what was done by NCATS was a clever technique, which is dideutyrium ketamine, where you strengthen the carbon 6, so when you take it, it can't be metabolized that easily by liver. So in essence, you separate the wheat from the chaff, so you can see where the D-ketamine is important, or the metabolite is important. And when we do that, we tested D-ketamine. You see here, no metabolites, or very little. And what happens? The rapid antidepressant effects are no longer there, but you still have the side effects and the addiction potential. Here, then, we saw in separate experiments that hydroxynorketamine has the rapid antidepressant effects without side effects and addiction. These are in mice. Okay, fantastic antidepressant in mice. But we have to study it in humans, and so we will do that shortly. So no abuse of potential, and that theory of it's necessary to block NMDA receptors, they didn't hold up. And that had been a theory for 20, 30 years. We actually don't find. So that means that perhaps we can develop drugs that don't have the side effects. Okay, now into the last 6 minutes or so, suicide. This is one of our third programs. Where everything I mentioned that we do with depression, we still do with suicide, people who just attempted suicide. So as you know, there are 45,000 suicides in a year. The rates are increasing. Everywhere in the country, darker colors are the greatest increase by 38 to 58%. To show you Oklahoma, unfortunately it's in a dark color. So suicide rates are gone. There are many, it's multifactorial. And you can see here the many states that are in darker colors. And if it continues at this rate, there will be about 54,000 suicides per year in the U.S. by 2025. Now, what is suicide? It's different than self-injurious behavior, where there is at least some intent. Self-injurious suicide, there should be at least some intent to die. These are the numbers: 1 million per year, 44,000 per year, about 300,000 emergency room visits per year. Similar strategy what I mentioned for depression. We're deconstructing the suicide from other disorders, and right now studying healthy volunteers who attempted suicide and patients with severe mental illness. So these are risk factors for suicide: previous suicide attempts, you have a mood disorder diagnosis, you abuse alcohol or drugs, multiple comorbidity. There's a dose effect. The more comorbid conditions, the greater the risk for suicide. Social isolation, and lack of access to clinical care, and of course the means. This is to show you, this is a study of the STEP-ED for bipolar disorder. Elizabeth Ballard and my group looked at months before the suicidal behavior. This represents several thousand individuals with bipolar disorder, 6 months, 5 months, 4 months, 3 months, 2 months. We know that the risk factors for suicide are suicidal thinking and anxiety. But look in green here. loss of interest or pleasure. Anhedonia is a risk factor for suicide, something that we as clinicians don't pay enough attention to. So these are current treatments for suicide, pharmacological treatments, and the only one approved is clozapine for schizophrenia, and lithium does have anti-suicidal effects, but these are behaviors or attempts or risk, but not on current suicidal thinking. So there are critical windows for the suicide risk, as I mentioned, the first week after admission and after discharge, and especially when starting an antidepressant. So unfortunately, our treatments have a considerable lag of onset of weeks to months. The same paradigm applies to depression as to suicide here. We want treatments that work within 40 minutes for suicide. And in fact, there is evidence for that. Just to give you a case vignette, here, keep in mind, includes the risk factors that I just mentioned. 59-year-old divorced, disabled, 47-year depression, multiple comorbidities, panic, GAD, 10 hospitalizations, 6 suicide attempts. Her mother had depression, paternal uncle was alcoholic, and lived alone with a cat. So 6 months prior to admission, significant depression, agitation, suicidal thinking. Those were the risk factors I mentioned. Probably also anhedonia. Feeling the worst I've ever felt when admitted to our unit. Strong thoughts to wanting to hang herself, images of killing herself, shooting herself with a gun. So these are the type of patients we study because they are deserving of better treatments. So ketamine, in addition, was found to have rapid anti-suicidal ideation effects. One infusion, this is a meta-analysis of several sites, showed within 40 minutes the suicidal thinking is gone and lasts 1 week. Okay, clinicians out there, is that important or not? Why? Okay, how much, our patients in the hospital for 2-3 days and we get nervous that they might do something, and insurance doesn't approve that, and we get nervous to getting them, to their treater. Here it gives us, buys us some time to get the family, the therapist involved. So these, I'm not saying it will be ketamine, but future treatments like this. So 50% achieve suicidal thinking is gone and lasts for at least 1 week. And this is what happened with Rosemary, one of our older subjects. She had one infusion of ketamine, all symptoms resolved within a few hours and stayed well for 20 days with no other treatment. She was drug-free. So there's something here. Not everybody responds, but can we identify who might respond? Okay, so this is some of the studies. I won't have time to get into it because I have to wrap up. We have fear, potentiate, startle. These are long-term risk factors, short-term risk factors in response to treatment. This is some of our work. We just published this month in JAMA, Psychiatry, familial transmission of suicide attempt, if you have interest, history of sexual abuse. It's linked to long-term risk for suicidal attempts. Gamma power in anterior insula is involved in short-term risk of suicidal thinking. Nocturnal wakefulness, I have an example here, glucose metabolism in anhedonia. And of course, some of these link to treatment responses. So this is kind of starting to provide a framework. I think I found this study interesting. These are the last 3 slides, I believe. Sleep difficulties are associated with future attempt. Tons of studies looking at sleep diaries, right? And what they identified between midnight and 5 a.m. is the greatest risk for suicide attempt. Why? Who wants to venture? Because of insomnia, you're alone, your thoughts are ruminating, you probably could drink if you can, or use benzos, so those are the risk factors. So we looked at it more systematically with polysomnography. This is what you find. To the left are depressed subjects, to the right, healthy control subjects. This is minutes awake between midnight and 4 a.m. Okay, your patients say, I can't sleep. Okay, here it is. Each line is an individual patient. You can see they're up a lot. Healthy control subjects, I don't sleep as well, but here you can see very little time awake. Okay? Then these subjects received ketamine, and we looked at the response. Okay. Now look at the sleep quality of those who have suicidal thinking, much more increased awakening compared to those who do not have suicidal thinking. Look at this group here, those who have suicidal thinking and receive ketamine. Look what happens in those who had I don't think I have it here, but these are the responders to ketamine. and the non-responders to ketamine in terms of suicidal thinking. So we thought that this slide was a mistake because it looked like the healthy control subject. No, these are the depressed patients after receiving, the suicidal patients after receiving ketamine. Normalization of the time awake. So this is an example of being able to use biomarkers. We have a study called the Neurobiology of Suicide, does the same things I mentioned. People who have attempted suicide in the past 2 weeks in several control groups. So to summarize, we're obtaining information at the cellular molecular level. I didn't give you all the details. We're obtaining information with novel treatments at the circuit system level. And hopefully with the human clinical trials, which are integrated with biomarkers, we can subgroup people to be able to determine who might have a better response down the road. So all of this is, this is the Intramural Research Unit, and these are, this is our staff collaborations, but I'd like to thank all of them, especially our patients and their families. None of this would have been possible without their contributions. So thank you for your attention. Yes.
So I know you're trying to look at who is this effective on, who is this at that time, who is responsive to studies. But right now, I'm just looking at the data that you have, if they respond negatively to the first dose they get, is that an indication that they should continue to try ketamine?
Right.
Or
Can we use, so the question is, can we use the response or non-response to the first dose of ketamine as a way of selecting who we should keep on giving or not? And so most of the response is with the first infusion. It's roughly probably 80%, but there's still, we thought that it was actually, you wouldn't get a response after, but the studies actually show that there's another 20-25% that could get response with continued treatment. But people are recommending in some groups, ketamine clinics, to do 2 weeks. So that would be 4 infusions, and then at that time they would give it up. But that's the suggestion. So, and again, keep in mind when we say response, okay, what if the depression is a little bit better, but they don't have suicidal thinking anymore, right? So the other is it also some people have benefit from the anxiolytic effects, right? So it all depends. I think it's a good way of buying time. And this is just anecdotal, but we don't have any evidence. But it seems some of the medicines that may have not worked may kick in and work a little bit better, the traditional medicines after ketamine treatment. And then of course there's a psychotherapy we could add to the medicines. I believe that psychotherapy might be accelerated. Okay. Other questions or comments? Yes?
You talk about developing biological markers with this quick treatment response. You actually have the ability to look at these systems that change, correlate with the subjective response. Are there any systems that you see where the response is most consistent with the subjective response? In other words, whether we talk inflammation, metabolism, any hints of which direction, which systems, because you talked about depression being a multi-system disease.
Yeah, so the question is, are there any hand-in-hand things in terms of systems that go with the system biological change that go with the symptom changes? It's very early work, but we were pretty impressed with the fMRI, the insula activity that seemed to have this kind of nice on-off effect. We are doing more complex analysis now, and in fact, it's unlikely to study a similar study of this type will get replicated, but we're doing a repeat dose ketamine now, where people get in the scanner, they receive either fMRI plus EEG. The same subject then gets MEG, and then they get some functional. So we'll know better. I think it's a bit too early to know which systems. We have a lot of hints and clues. The problem with hints and clues, they're hints and clues, and we have to make sure they're replicated. Yes?
So outside of the glutamatergic system, have you put any thought to how ketamine's reacting to these GABAergic interneurons and whether there's any low-hanging fruits in that domain?
Yeah, let's see. Unfortunately, that was would have been more of my cellular molecular talk, but just so ketamine binds to the NMDA receptor and GABA interneurons. When it does that, it produces this inhibition of pyramidal cells, and you have that flood of glutamate that hits the AMPA receptor. Just to here, right here. So it would hit the AMPA receptor here, because you get this flood of glutamate, and that leads to increases of BDNF, brain-derived neurotrophic factor, and those are the factors that make the synapses and circuits, grow. We have 3 candidate drugs. One is, or 2 candidate drugs for now. One is we just published last week that ketamine's effect might be by mGluR2 antagonism. Here it is. This is a thermostat of the glutamate system, regulates how much glutamate. And when we block this, you can also produce this flood of glutamate that targets AMPA receptors, but without having to block the NMDA receptors, that lead to the side effects and abuse. The other is GABA-A drugs are available. That you don't have to bind to the NMDA receptor within the GABA receptors. You can go directly to the GABA receptor. So there are ways of avoiding traffic, or the key area, which is NMDA. So there's in the hydroxynorketamine metabolite as well. So we have 3 candidate drugs that 2 will start in a couple of months in healthy control subjects to start next year, and then the GABA drug might be after that. So that's kind of the exciting part. I think it's important. We've gone from developing drugs years ago where you're doing some animals, and the rat looks depressed, and maybe that protein is responsible to develop a drug for that. That would be 15 years and $10 billion. Where we have something we know works, let's go backwards, back translate, and figure out what are the targets. I think that's probably going to be a more fruitful approach. We'll see. All right, I think yes, go ahead.
Has ketamine been tested in patients with psychotic features? Is it particularly effective in that?
So has ketamine been tested in patients with psychotic features? The answer is yes. Clinically, not a study. I'm aware, I think, of 2 cases. One was a case reported out of Yale on 2 patients with psychotic depression. And this has been something that's always intrigued investigators. Schizoaffective disorder, right? Does the psychosis and depression get better at the same time, or psychotic depression? And so what they did is they gave ketamine psychotic depression, and the subjects got better in terms of depression and psychosis. So it's not that depression got better, psychosis lingered, or the other way around. In another case series, one other case report, I'll take that. I don't know if it's a good idea to do or not, but certainly an intriguing question. Yeah.
What about the disassociative piece?
What about the dissociative side effects? So ketamine produces the dissociative side effects, which is different than the psychotomimetic. So you have the psychosis aspect, which you have disorganization, suspiciousness, and you might hear noises. And dissociation is you're disconnected from your body, right? It's not. They're different. Now, but if you believe in this homeostatic mechanism, right? Should ketamine work in PTSD? Right? So if you remember that cartoon I showed you, I think we have a few minutes. I think this is interesting. Myself. Here, this inverted U shape, and this is where I think it applies to different things. Here it is. So let's say, okay, ketamine produces dissociation. People with PTSD have dissociation, right? And the study done by Mount Sinai, Adriana Feder with Dennis Charney, small study, but did find, and they used midazolam as a control, did actually find that the dissociative symptoms got better. Interesting. Now this was on civilian PTSD, not military PTSD. So is it possible that they might start here in terms of the dissociative symptoms, and you get to the sweet spot, but some people with some biological marker at the higher end, so you actually push the envelope and it got better. Now I'm not saying you should do this, but it's intriguing. It's very intriguing. So this challenges our notions of how we think about biology and symptoms and treatment. So, anyhow. All right, and any other last questions before we wrap up? Okay, thank you for your attention.